all viewers for this scientific webinar, which we are going to conduct under the banner of Indian Diabetes and Cardiometabolic Diseases Association. Today's eminent panel member consists of Dr. Ms. Anuradha Kapoor. She is from Mumbai. Dr. Akash Kumar Singh, he is from Baroda. Dr. Kamaldeep Chawla, he is also from Baroda. Dr. Vishal Chawdhari, he is from Mumbai. And Dr. K Bhaskar, he is from Pune. Dr. Vishal Chawdhari will be moderating today's academic session. And Dr. Anuradha Kapoor, Dr. Akash Kumar Singh, Dr. Kamaldeep Chawla, and Dr. K Bhaskar are speaker for this program. So let me have the slide of Dr. Vishal Chawdhari. Yeah. Dr. Vishal Chawdhari, slide of Dr. Vishal's introduction slide of Dr. Vishal Chawdhari. Sir, second one. Second one. Yeah. Yes. So I am just giving a brief introduction of today's moderator, Dr. Vishal Chawdhari. Dr. Vishal Chawdhari is Medical Director of Sai Jyoti Multi-Speciality Hospital, Mumbai, accredited with various certification courses from American Diabetes Association, Indian Lipidology Association, Indian Thyroid Society, and Endocrine Society. Has been a part of research trial like landmark clinical trials, study in diabetes, Impact India study on insulins, has attended n number of national and international conferences like ADA, EASD, ESC, RSSDI, and Mayo. Frequently organizes various patient awareness related initiatives such as medical camps and awareness meetings. So this is a brief introduction of Dr. Vishal Chawdhari. Since he is the moderator of today's session, so now I would like to hand over the session to Dr. Vishal Chawdhari. Over to you, sir.
Okay, thank you very much for the nice introduction. Dr. Vishal Chawdhari. Today, there is no slide visible. There is no slide visible.
I hope, sir, this is visible now, sir. Yeah.
Okay, so today's this particular sessions we are starting off today with Dr. Anuradha Kapoor, who is from Mumbai. We will be talking about pathophysiology of hypertension. She is MBBS MD Fellowship in Diabetes. She is consultant diabetologist at Zenith Multi-Speciality Hospital, Mumbai. And there is around 2 decades of work experience in field of diabetology and preventive medicine, academic advisor and course director, certificate course of diabetes management with the Quest Healthcare India, physician partner with British Lim Mumbai, has done various certificate courses from reputed national and international institutes. Author of the book Management of Diabetes Mellitus, a complete practical guide, and instrumental and actively involved in medical techniques, medical teachings, and book writing. There is a special interest in preventive diabetology. So over to Dr. Anuradha Kapoor for the lecture.
Hello. Yeah. Okay. Hello, friends. Thanks for joining this webinar. I will keep my topic as short as I can. So I will cover only important pathophysiological changes. So as we all know, hypertension or elevated blood pressure is a serious medical condition that significantly increases the risk of heart, brain, kidney, and other diseases. And hypertension is the leading cause of cardiovascular disease and premature death worldwide. So, in accordance with most major guidelines, it is recommended that hypertension be diagnosed when a person's systolic blood pressure in the office is 140 or more, and their diastolic blood pressure 90 or more millimeter mercury following repeated examinations. So there are two types of high blood pressure we all know. For most of the adult, approximately 90% cases, there is no identifiable cause of high blood pressure. This type of high blood pressure tends to develop gradually over many years. And some people, approximately 10%, have high blood pressure caused by underlying conditions. This type of high blood pressure tends to appear suddenly and cause higher blood pressure than does primary hypertension. Various conditions and medications can lead to high blood pressure. They're listed in this table. So there are many risk factors for high blood pressure as listed in the table. Although high blood pressure is most common in adults, children may be at risk too. For some children, high blood pressure is caused by problems with the kidney or heart, but for a growing number of kids, poor lifestyle habits such as unhealthy diet, obesity, lack of exercise contribute to high blood pressure. Now, pathogenesis of hypertension. There is still much uncertainty about the pathophysiology of hypertension, as only a small number of patients have an underlying renal or adrenal disease as a cause for their raised blood pressure. A number of physiological mechanisms listed in this table are involved in the maintenance of normal blood pressure, and their derangement may play a part in the development of essential hypertension. It is also probable that there are many interrelated factors contribute to the raised blood pressure in hypertensive patients, and their relative roles may differ between individuals. So, maintenance of a normal blood pressure is dependent on the balance between cardiac output and peripheral resistance. Most patients with essential hypertension have a normal cardiac output, but a raised peripheral resistance. It has been postulated that in very early hypertension, the peripheral resistance is not raised, and the elevation of the blood pressure is caused by a raised cardiac output, which is related to sympathetic overactivity. The subsequent rise in blood pressure the subsequent rise in peripheral arteriolar resistance might therefore develop in a compensatory manner to prevent the raised pressure being transmitted to capillary bed, where it would substantially affect cell homeostasis. Now, increased peripheral resistance. Increase in the peripheral resistance is determined not by large arteries or the capillaries, but by small arterioles, the walls of which contain smooth muscle cells. Two mechanisms are involved: remodeling of smooth muscle leading to narrowing of the arteries, and prolonged contraction of the smooth muscle. So remodeling of smooth muscle. Vascular smooth muscle cells are an important component of blood vessel or schematic representation of anatomy of venous arteries and capillaries wall are given here. It is shown in this wall of a vessel has three layers: external, middle, and inner layer. Muscle cells are located in this middle layer, and muscle cells are located in this middle layer of the blood vessels, where they are oriented in a circle around the vascular lumen and form numerous layers. In medium vessels, there are up to 40 layers of vascular smooth muscle cells, and in large vessels, there are up to 60 layers. So, inner layer contains a semi-permeable monolayer of endothelial cells, we all know. So this structure is similar in arteries and veins. In vein, the tunica media is usually thinner. Smallest blood vessel capillaries lack these classical layers of blood vessel wall. They consist only of fine tubular structure built of endothelial cells, which is surrounded by pericytes, which are somewhat like vascular smooth muscle cells. So vascular smooth muscle cells play important role in the physiological function of the blood vessel, such as vasoconstriction, vasodilatation, and extracellular matrix production. And in this way, they make a marked contribution to regulation of blood pressure. In healthy adult blood vessel, vascular smooth muscle cells are highly differentiated and normally maintain a contractile phenotype. We call it non-proliferative phenotype. This phenotype is characterized by specific markers of vascular smooth muscle cells differentiation as shown in this slide. However, in pathologically challenged blood vessel or under pathological condition accompanying the onset and development of vascular diseases, vascular smooth muscle cells undergo a process referred to as phenotypic modulation. That is, they switch from contractile phenotype to the synthetic phenotype characterized by a loss of contractile filament and associated molecule, loss of differentiation marker, and by increased formation of organelles. Active migration and proliferation or hyperplasia, and that means there is increase in the vascular smooth muscle cells volume. Now, and polypolarity of vascular smooth muscle cells. The polypolarity of vascular smooth muscle cells are specific to systemic hypertension. This feature is absent in pulmonary hypertension, and with increasing age, the number of polypolarity vascular smooth muscle cells can reach several tens. For this reason, the polypolarity of vascular smooth muscle cells has been proposed as a biomarker of senescence. In addition, not only vascular smooth muscle cells in the tunica media, but also fibroblasts in the tunica adventitia migrate, proliferate, and undergo inflammatory activation, and they therefore contribute to vascular remodeling. So this vascular smooth muscle cells behavior can lead to remodeling of the vascular wall, including stenosis and obliteration of the vascular lumen. Second mechanism is contraction of smooth muscle cells. Vascular contraction relaxation is regulated by many processes that are both calcium dependent and independent and involve calcium channels and signaling pathways. Vascular smooth muscle cells, like all other muscle cells, depend on calcium to initiate contraction, and contraction is triggered by the increase in the intracellular free calcium concentration, prompting acting myosin cross bridge formation as shown in this slide. This calcium can enter the cell from two sources, extracellular space, or it can be released from largest intracellular calcium stores or sarcoplasmic reticulum. Extracellular calcium influx is mainly mediated by the opening of L-type calcium channel, and while intracellular calcium influx is mediated by opening of number of other channels. So because of their high single channel conductance and expression in vascular smooth muscle cells, this L-type calcium channel have the largest influence on global calcium influx, and their activity largely determines the vascular smooth muscle cells contractile state and ultimately vessel diameter. In hypertension, these processes are dysregulated, and signaling pathways not typically associated with contraction like tyrosine kinase and transcription factors are activated. These phenomena lead to hypercontractile state and prolonged smooth muscle constriction, and that is thought to induce structural changes with the thickening of the arteriolar vessel wall, possibly mediated by angiotensin, leading to an irreversible rise in peripheral resistance. And this mechanism may explain the vasodilatory effect of drugs that block the calcium channels, means calcium channel blocker drugs. Now, second pathophysiological mechanism is autonomic nervous system stimulation. So hypertension is related to abnormalities in autonomic nervous system function with increased sympathetic output and decreased parasympathetic tone. The sympathetic nervous system is one of the central pathways in the pathophysiology of hypertension, both through its own effects on the heart and vasculature and through its interaction with the renin-angiotensin-aldosterone system. So sympathetic nerve terminal secrete adrenergic substance, norepinephrine and epinephrine. We all know these. These substances act by binding through adrenergic receptors. These receptors are of two types, alpha and beta, and they are again subdivided into alpha 1, alpha 2, beta 1 and beta 2 receptors. So stimulation of beta receptor system. Beta receptor system, most tissues express multiple receptors. Beta receptors are present on heart. Predominant receptors here are beta 1, smooth muscles of blood vessels. Predominant receptors here are beta 2, and smooth muscles of non-vascular organs like bronchioles. Predominant receptors are here beta 2 receptors. Now, effect of beta 1 receptor activation on the heart is shown in this diagram. When beta 1 receptors are stimulated, they increase the heart rate and increase the heart's strength of contraction or contractility as shown in this figure. So overstimulation will result in increase in the cardiac output and hence systemic arterial blood pressure. So beta 1 receptor also induce renin release, and this lead to an increase in the blood pressure. Now, effect of beta 2 receptor stimulation. So the beta 2 receptors are located in the bronchioles of the lungs and the arteries of the skeletal muscles. So activation of beta 2 receptor lead to vascular and non-vascular smooth muscle relaxation, along with increased metabolic effects such as glycosenolysis. So drugs that activate the beta 2 receptor can be used to treat as asthma by relaxing airway smooth muscles and premature labor by relaxing uterine smooth muscles. So our beta blockers are the drugs that target this pathological mechanism, and because of different role of beta 1 and beta 2 receptors, beta blocker drugs that with beta 1 selectivity will block only beta 1 receptors present on smooth muscles of the heart and decrease blood pressure, but non-selective beta blockers drugs will also block beta 2 receptors present on bronchioles smooth muscles, and that will result in side effects like bronchial obstruction. Now, stimulation of alpha receptor system. The receptors mediating the vasoconstrictor action of catecholamines is referred to as an alpha receptor system. Both epinephrine, norepinephrine activate both the alpha 1 and alpha 2 receptors. Alpha 2 receptors are present presynaptic nerve ending, and activation of these receptors inhibits the release of norepinephrine. Alpha 1 receptors are present mainly on the vascular smooth muscle cells, and here they are present in large number as compared to beta 2 receptors. So overactivation of these receptors by sympathetic nervous system transmission or drugs will result in vasoconstriction and increase in the peripheral resistance and systemic arterial blood pressure. So alpha blocker drugs target this pathological mechanism of blood pressure and result in vasodilatation and decrease in the peripheral resistance, hence blood pressure. Now, role of renin-angiotensin-aldosterone system, and to understand this, we need to review our renal handling of sodium and water and how the kidney filters fluid and forms urine. So functions of kidney we all know, and we know that renal processes involve filtration at the glomerulus, reabsorption of water and electrolyte, active tubular secretion and of organic acids and bases, and finally formation of urine. So if we see the structure of kidneys are made up of thousands of tiny tubule or nephrons. Each nephrons begins in the cortex and then it loops down in the medulla, then back ascends back into the cortex and then again goes down through the medulla and then to the pelvis, finally joins the ureter. And in this finally it joins the ureter. And so tubular reabsorption and formation of urine. As blood flows through the kidney, it passes into glomerular capillaries and located within the cortex. These capillaries are highly permeable to water and electrolyte. So glomerular capillaries hydrostatic pressure filters water and electrolyte into Bowman's space and into the proximal convoluted tubule. About 20% of the plasma that enters the glomerular capillaries is filtered, termed filtration fraction. During this passage of plasma, many nutrients are reabsorbed and many nutrients are actively secreted into the filtrate, and finally urine is formed. So urine is formed in three main steps: glomerular filtration, reabsorption, and secretion. And we all know it comprises 95% of water, 5% of waste such as ions of sodium, potassium, calcium, and nitrogenous waste such as creatinine, urea, and ammonia. Now, glomerular filtrate from Bowman's capsule to in the different part of nephron. Passage of filtrate is summarized in this slide. So from Bowman capsule, filtrate enters into the proximal convoluted tubule, and here 65 to 70% of sodium and 85% of sodium bicarbonate are normally reabsorbed, and 65 to 70% of sodium is reabsorbed isotonically, means along with this equal amount of water is also reabsorbed, and reabsorption of this 85% of sodium bicarbonate is catalyzed by an enzyme carbonic anhydrase. This is a reversible reaction and diuretic action of acetazolamide due to the inhibition of this enzyme, we all know, and the result is renal loss of bicarbonate, which carries out a little sodium, water, and potassium. That is why it is a weak diuretic. This enters into the proximal. From here, it enters into the loop of Henle, and which is permeable to water. Water is reabsorbed from the loop of Henle. This loss of water concentrates the urine within the loop of Henle, and from here it enters into the thick ascending limb of loop of Henle, which is impermeable to water, has a co-transport system that reabsorbs sodium, potassium, chloride at a ratio of 1:2. Approximately 25% of sodium load of the original filtrate is reabsorbed at the thick ascending limb, and that is why we know this is site of action of loop diuretic, and that also explains why it is a potent diuretic. Now, from the thick ascending limb of loop of Henle, fluid flows into the distal convoluted tubule. Here again, with the help of sodium chloride co-transporter, approximately 5% of sodium is reabsorbed, and this is also impermeable to water, and we know this is the site of thiazide and thiazide-like diuretic, and this explains why it is a medium potency diuretic. Finally, filtrate enters into the collecting duct. So here also, with the help of sodium chloride co-transporter, 1 to 2% of filtered sodium is reabsorbed. Sodium in exchange for potassium and hydrogen ion, which are excreted into the urine. It is important to note two things about this transporter. First, its activity is dependent on the aldosterone, which is a mineralocorticoid hormones we all know, secreted by the adrenal cortex. Increased aldosterone stimulate the reabsorption of sodium, which also increases the loss of potassium and hydrogen ion to the urine. This is the site of action of potassium diuretic, that is also a low potency diuretic. Finally, this filtrate enters into the collecting duct, and which is again permeable to water, and with the help of ADH hormones that is secreted from the posterior pituitary, which lead to increased water reabsorption of more concentrated urine and reduces urine outflow. So nearly all of the sodium originally filtered is reabsorbed by the kidney. So less than 1% of originally filtered sodium remains in the urine. And Already I have discussed the diuretic target these sites for their diuretic action. So increased volume load because of the increased reabsorption of sodium and water due to the hyperactivity of the renin-angiotensin aldosterone system is one of the cause of hypertension. So what is the mechanism of renin-angiotensin aldosterone system? The renin-angiotensin aldosterone system, or RAS, is a system to regulate blood pressure and fluid balance in the body. It is most important of the endocrine system that affect the control of blood pressure. The RAS functions to elevate blood pressure, arterial tone in a prolonged manner. It does this by increasing sodium reabsorption, water reabsorption, and vascular tone. So within the afferent arterioles of the kidney, there are specialized cells. We call it juxtaglomerular or JG cells, contain prorenin that is secreted in its active form. Activation of JG cells causes the cleavage of prorenin to renin. Now, activation of these cells occurs in response to decreased arterial pressure in the blood, decreased sodium, and increased sympathetic tone. Once renin is released into the blood, it acts on its substrate, angiotensinogen. This is secreted from the liver. Renin converts angiotensinogen into angiotensin 1. Then angiotensin 1 is converted into angiotensin 2 by the action of enzyme ACE inhibitor that is secreted from the lungs. And this angiotensin 2, this acts this angiotensin 2 is the main agent involved in the blood pressure regulation. This enzyme acts via angiotensin 2 receptors. They are of two types, type 1 and type 2. So, angiotensin 2 exerts its effects by binding to angiotensin 2 receptor. Type 1 and type 2 present on the adrenal gland, kidney, brain, heart, and blood vessels. So, action of the angiotensin 2 is summarized here in the adrenal gland. Angiotensin 2 acts on specifically the zona glomerulosa of the adrenal cortex and stimulate the release of aldosterone. And aldosterone, we just discussed, it is a steroid hormone that works by stimulating the insertion of luminal sodium channels and basolateral sodium potassium ATPase proteins. The net effect is increase in the sodium reabsorption and potassium excretion at the distal tubule, and collecting duct of the nephrons, and the increased total body sodium lead to an increase in the osmolarity and subsequent increase in blood and ECM volume. So aldosterone thus promotes sodium and water retention in the kidney. Now in the kidneys, in the proximal convoluted tubule of the kidney, this angiotensin 2 acts to increase sodium hydrogen exchange, increasing sodium reabsorption, and increased level of sodium in the body acts to increase the osmolarity of the blood, leading to a shift of fluid into the blood volume and extracellular space. This promotes sodium and water retention in the kidneys. This increases the arterial pressure of the patient. In the heart, angiotensin 2 stimulate muscle hypertrophy, fibrosis, and increase contractility, and because of that, cardiac output is increased. In the smooth muscles, angiotensin 2 increases vasoconstriction, and finally, angiotensin 2 acts on the brain, and angiotensin 2 stimulates sympathetic outflow in brain. Here, it has three effects. First, it binds to hypothalamus, stimulating thirst and increase water intake. Second, it stimulates the release of antidiuretic hormones by the posterior pituitary. So this ADH or vasopressin acts to increase water reabsorption in the kidney by inserting aquaporin channels at the collecting duct. Finally, angiotensin 2 decrease the sensitivity of the baroreceptor reflex. This diminishes baroreceptor response to an increase in blood pressure, which could be counterproductive to the goal of RAS. Now, the net effect of these interactions, as shown in this slide, is increased total sodium, body sodium, total body water, and vascular tone and blood pressure. Now, what is the clinical significance of RAS? The RAS acts to manage blood volume and arteriolar tone on a long-term basis, while minor and rapid shift are typically managed via baroreceptor reflex. The RAS can alter blood volume chronically. Through the RAS, So though the RAS serve a critical function, it can be activated inappropriately in several conditions that may lead to development of hypertension. For example, renal artery stenosis result in decreased volume of blood reaching to one or both kidneys. As a result, JG cells will sense a decrease in blood volume and they will activate RAS. This can lead to inappropriate elevation of circulating blood volume and arteriolar tone due to poor renal perfusion. Pharmacologically, the RAS is a frequent manipulated system in the management of heart failure and myocardial infarction, hypertension, diabetes, and antihypertensive drug, AC inhibitor, ERBs, they act by blocking RAS, and renin inhibitor, they act by blocking RAS at different levels. And there are many, as I already told, there are many other factors. They are known as interrelated factors like increase in the salt intake, endothelial dysfunction, and vasoactive substances like bradykinin, insulin resistance syndrome, genetics, intrauterine influences, vascular inflammation that I'm not going to discuss in detail. So in conclusion, derangement and hyperactivation of all above physiological mechanism along with interaction with these above mentioned interrelated factors are involved in pathogenesis of high blood pressure. So this is the end of session. Thank you.
Thank you, Chandra. Dr. Vishal, please.
Yes, thank you very much, Dr. Anuradha, for the very nicely explained pathophysiology of hypertension. It's a very complicated topic and basic topic, but complicated topic, very nicely explained.
Thank you.
Yeah.
Should I stop sharing?
Yes,
Please
yes.
stop. Please stop.
Okay.
So further slides can be shown to me.
Till the slides are uploaded, Vishal, just talk a brief about the new association.
Association, okay. I think so today we will be having another session of Dr. Kamaldeep Chawla, who is MD Medicine, DNB Cardiology, Fellowship in Interventional Cardiology, done from the France. So he is a director and consultant cardiologist at Sterling Hospital, Vadodara, head and senior interventional cardiologist, Cambe Cardiac Center, Khambat, Anand. Instrumental in conducting the trials and research such as HERO 2, Create, Oasis 6, Reality, etc. Principal investigator of prominent Tuxedo 2 studies. Published many papers, articles in reputed journals, textbooks, and handbooks. Has been chief organizer, advisor, and program coordinator to several academic events such as Hypertension Update, Cardiology Update, Cardio Nephro Update, World Congress of the IPCA Stroke Update, EPCON, and many more. Invited as guest faculty to many national and international conferences of cardiology. Recipient of various awards, including Best Cardiologist in Western India. So today we'll be sharing a topic of hypertension guidelines, role and types of diuretics for the hypertension control. So over to you, Dr. Kamaldeep, sir.
Yeah, good afternoon, esteemed faculty and participants. So I'm going to talk on hypertension guidelines and role and types of diuretics for hypertension control. So it's a big topic by itself, but I think I'll have to do justice to time. And so are my slides visible?
Yes, yes.
Yes.
So the background is substantial progress has been made to understand hypertension in terms of epidemiology, pathophysiology, and risk assessment.
Kamal, you enlarge your slides. Enlarge your slides.
Sir, keep on slideshow mode.
Yeah, is it okay now?
Yes, sir. Continue.
Yes, yes.
Okay. So, sorry. There's bundle of evidence supporting that controlling BP can significantly reduce premature morbidity and mortality. And every year we get some new guidelines, and which many times are practice-changing guidelines, and then we have to be updated with them. So I will be focusing on the guidelines that we actually follow from the previous years and what do we have this year new in terms of that. So after JNC 7, we got JNC 8 guidelines, and they were really confusing. In between, we got nice guidelines, but then ACCA HA 2017 classification of BP became like sort of benchmark, wherein normal BP was less than 120 and less than 80, and elevated BP was defined as 120 to 129 and diastolic less than 80, and stage 1 hypertension defined as 130 to 139 or 80 to 89 millimeters of mercury, and stage 2 more than 140, more than 90. So any individual with systolic and diastolic BP in two categories with this definition was defined as hypertensive, and we were all told that 130 is the new 140. This is a brief comparison of existing norms at that particular time, 2017-18, wherein JNC 7 defined BP as normal BP less than 120 and less than 80, and then pre-hypertension up to 140, and then stage 1 hypertension and stage 2 hypertension. And stage 1 hypertension was 140 to 159 and 90 to 99, and stage 2 hypertension was more than 160. And then 2017 ACCHA guidelines brought the new focus of normal BP, elevated BP, and stage 1 hypertension up to 140 by 90, and anything more than that as stage 2 hypertension, because the main focus was to reduce the number of incidences in these patients. And then Indian hypertension guideline approximately at that particular time said that less than 120 and less than 80 was optimum, 120 to 129 and less than 80 was normal, and then pre-hypertension was high normal, and then they tried to bring a balance between the JNC 7 guidelines and the 2017 guidelines defining 140 to 100 at stage 1 and more than 160 to by 100 at stage 2. Then came, sorry, CRISP guidelines elucidated very nicely ESC 2018 classification of BP, wherein they again said that optimal BP was less than 120 by 80, normal 120 to 129 and 80 to 84, high normal 130 to 139 and 85 by 89 is high normal, and defined hypertension as grade 1, grade 2, grade 3, and focus on isolated systolic hypertension as BP more than 140 by 90. So the new thing was that grade 3 hypertension, which was previously there in JNC 6 and JNC 7 guidelines, was again brought into by ESC 2018 guidelines. And a new focus came about 140 by 90 as office BP, that's what we measure in our clinics. And ambulatory BP, what we apply the ambulatory BP monitor on our patients as 135 and above 89 as defined as hypertension of daytime. And home BP systolic more than 135 was defined as hypertension. So there were many converging and divergence points up to this point of time, 2018, 2019, wherein the ACC said that 130 by 80 and European guidelines said 140 by 90 as hypertension definitions. However, both agreed to one thing, and that was that less than 130 and 80 was the BP treatment goal at that particular time. So though there was a discrepancy in labeling hypertension as stage 1 hypertension and then going up to stage 3 hypertension, both the guidelines at that particular time converged and took a decision that less than 130 by 80 was the target that had to be done. Why this happened was because the American guidelines relied heavily on clinical studies. So somebody is interfering. And the European guidelines were basically relying on the epidemiological observations. And so the ESC hypertension guidelines were basically the new focus, and that we obeyed. And optimal BP less than 120 by 80, normal BP 120 by 129 to 80 by 84, and high normal. So this is where they brought in ABPM, and they said that we should always consider masked hypertension and white coat hypertension.
Hello.
And rely more on out of
दुसरं एक लेक्चर आहे त्याच्यामध्ये ना आम्ही मॉडरेटर आहे आम्ही आणि बाकीचे स्पीकर आहेत 3-4 जण ते काय चालू आहे ते चालू आहे बोर
Vishal, mute the mic. Vishal, mute the mic.
Should I continue?
Yes, sir. Continue.
Yes, sir. Please.
Yeah. So what is new and what changed between 2013 and 2018? This is I've just prepared to take all of us through the journey. So the diagnosis changed and ABPM and home BP monitoring were brought into focus. The treatment of low grade 1 hypertension in patients with grade 1 hypertension at low to moderate risk and without evidence of target organ damage, BP lowering treatment is recommended if the patient remains hypertensive after a period of lifestyle intervention. So this was something new that 2018 said that always focus first on lifestyle intervention and then start on a monotherapy or something of that sort. In older patients, 2018 guidelines had a change in their focus from 2013 that BP lowering, drug treatment and lifestyle intervention is recommended in fit older patients more than 65 years. Previous focus was 80 years, and when systolic is in the range of 140 to 159, we start with class 1 treatment. Sorry. So this was the new focus wherein they said that in age more than 65 years, which was previously said that age more than 80 years. They also said that the BP treatment targets in older patients, that is 65 to 80 years. In older patients more than 65 years, it is recommended that systolic BP should be targeted to a BP range of 130 to 139. And diastolic target of less than 80 should be considered for all hypertensive patients, independent of the level of risk and comorbidities. Also, the initiation of drug treatment is recommended to initiate an antihypertensive treatment with 2 drug combination. This was the first time that the focus was brought from single pill to a combination pill. They also focused on resistant hypertension, that we should add spironolactone as a diuretic before labeling a patient as resistant hypertension. And in 2013, there was a lot of focus on device-based treatment for hypertension, particularly RDN, that is renal denervation. And in 2013, based on all the trials and clinical studies, they came out, the focus shifted that use of device-based therapies is not recommended for routine treatment of hypertension, majorly because the SPRINT trial failed at that particular point of time. So treatment of hypertension was justified and it remained for a couple of years, and I think we still follow some of the basic things from this 2018 guidelines, that first consider lifestyle modification, consider drug treatment in very high risk patients with cardiovascular disease, especially coronary artery disease. In grade 1 hypertension with lifestyle, immediate drug treatment in high risk or very high risk patients, and drug treatment in low or moderate risk patients without cardiovascular disease, renal disease or organ damage, that is hypertension mediated organ damage, after 3 to 6 months of lifestyle intervention if BP is not controlled. So the focus was that if any of the risk factors are there in terms of CVD, renal disease or HMOD, even grade 1 hypertension, go on to immediately start the treatment. And in low or moderate risk patients, initially try 3 to 6 months of good lifestyle intervention, and if BP is not controlled, go on to the medications. Grade 2, immediate treatment of all patients and aim for BP control within 3 months. And in grade 3, immediate drug treatment of all patients and aim for BP control within 3 months. So very crisp guidelines came out for uncomplicated hypertension that the first pill should be a dual combination of ACE inhibitor or ARB plus a calcium channel blocker or a diuretic. They said that consider monotherapy in low risk grade 1 hypertension or in very old patients who are very frail, because we don't want to decrease the BP tremendously. Step 2 was to either an ACE inhibitor or an ARB plus calcium channel blocker plus a diuretic. So the diuretic was brought into focus as step 2 in the triple combination. And for resistant hypertension, add spironolactone or other diuretic alpha blockers or beta blockers and consider referring to a specialist center. Beta blockers were to be specifically considered if there was a concomitant comorbidity like heart failure, angina, post-MI status, atrial fibrillation, and younger women with planning for pregnancy. In coronary artery disease, beta blockers came early into the recommendation and rest of the recommendations remain same. In hypertension with CKD, the first step was either an ACE inhibitor or an ARB plus a calcium channel blocker, or ACE inhibitors, ARBs along with a loop diuretic was to be considered. Step 2 was ACE inhibitor or ARB that we continue up to the maximum dose plus a calcium channel blocker plus a diuretic. And for resistant hypertension, use spironolactone but keep focus on potassium. Beta blockers were to be considered in CKD patients at any treatment step when there is specific indication that we have already discussed. A reduction in eGFR and a rise in serum creatinine is expected in patients with CKD who receive BP lowering therapy, especially in those treated with ACE inhibitors or ARBs, but a rise in serum creatinine of more than 30% should prompt evaluation of patients for possible renovascular disease. This was very crisply defined for the first time after GNC7, wherein this value was 35%, and in 2018 ESC guidelines, a 30% value jump in serum creatinine was the alarm bell that was to be used. In hypertension with heart failure, that is with reduced ejection fraction, the initial therapy should be ACE inhibitors or ARBs plus a diuretic plus a beta blocker. And step 2 should be, along with this, a mineralocorticoid receptor antagonist. Again, in AF, the focus is on beta blockers for rhythm control. Now we have International Society of Hypertension 2020 guidelines. If I go into the details of this, it's altogether a CME by itself. But the new thing that has come up in 2020, very crisp, very elaborate guidelines focusing on all areas of hypertension. And they have defined that risk factors in terms of comorbidities, in terms of hypertension-mediated organ damage or disease. If there is no other risk factor, a high normal BP is 130 to 139 and a diastolic of 85 to 89. Grade 1 hypertension is 140 to 159 and 90 to 99, and grade 2 is more than 160 by 100. So if we take the 2020 guidelines after all major recent meta-analysis and trials, I think best is to stick to a target of less than 140 by 90 as a normotensive high normal guy. The aim is less than 130 by 180. Grade 1 hypertension is 140 to 159 and 90 to 99 of diastolic, and grade 2 more than 160 by 100 is grade 2. So no grade 3 and all those. I think the ambiguity and all those divergences are resolved with these 2020 guidelines. Sorry. And then you add on to the risk of these patients once you have defined the level of hypertension as high normal, grade 1 and grade 2, low risk, moderate risk, and high risk as shown in the slide. They have also put a focus on elevated serum uric acid in patients with hypertension, which should be treated with diet, urate influencing drugs, or urate lowering drugs in symptomatic patients. And also an increase in cardiovascular risk must be considered in patients with hypertension and chronic inflammatory diseases like COPD, psychiatric disorders, psychosocial stresses, where an effective BP control is warranted. The 2020 guidelines crisply lay out that the established diagnosis of hypertension immediately go on to lifestyle modification, and if grade 1 hypertension, either it's essential or optimal immediate drug treatment in high risk patients. If there is limited availability of drugs, this is the focus that they have brought in 2020 guidelines. And if this limited availability exists, in those at lower risk, supply lifestyle intervention for 3 to 6 months. If BP is still not controlled, and where possible, start drug treatment in those aged 50 to 80 years. So again, that ambiguity of 65 to 80 years is removed. And if drugs are available, go on to a drug treatment in low to moderate risk patients without CVD, CKD, diabetes, or HMOD after 3 to 6 months of lifestyle intervention if BP is still not controlled. So they have tried to merge good points of the previous guidelines. And grade 2 hypertension, immediately go on to drug treatment in all the patients. Use whatever drugs are available with as many of the ideal characteristics as possible. Use free combinations if single pill combinations are not available or unaffordable. Use thiazide diuretics if thiazide-like diuretics are not available, and use alternative to DHP CSCDs if these are not available or not tolerated. So again, the optimal treatment pattern is dual low dose combination, either ACE inhibitors plus a calcium channel blocker, sorry. Step 2 is dual full dose combination. I mean, you go on to the fully tolerated doses of an ACE inhibitor, ARB plus calcium channel blocker. And step 3 is to add a diuretic. And step 4, resistant hypertension, add spironolactone in 12.5 to 50 milligrams of OD doses. So very crisp and clear guidelines have come out in 2020. Consider beta blockers at any treatment step when there is a specific indication for their use, as we have previously defined. So beta blockers are not totally out. Diuretics are not the king or the queen of hypertension treatment. And this is what 2020 guidelines have told us. Now I'll go on to brief discussion of role and types of diuretics. That is my topic for today's discussion. So we have ACE inhibitors, we have ARBs, diuretics, calcium antagonists, and beta blockers. And JNC 8, JNC 7, National Hypertension Guidelines, AHA, ESC, WHO guidelines. In all, first line of drug therapy is diuretic, definitely. So are ACE inhibitors, ARBs, and calcium antagonists. It's only beta blockers which were the first line of therapy in JNC 7 and the ESC guidelines previously. However, in the rest of the things, beta blockers are not the first line of therapy. So diuretics are basically divided into the site of, as per the site of action, which Madam has beautifully explained in her slides. So they are loop diuretics, which basically act on the ascending limb of loop of Henle to inhibit chloride and sodium reabsorption and thereby causing the urine to flow and reduction in cardiac output and thereby leading to reduction in hypertension. Then we have thiazide or thiazide-like diuretics, which are hydrochlorothiazide, and indapamide or chlorthalidone, which are thiazide-like diuretics. They have robust clinical data with them as compared to thiazide, and the ADRs or SACs are significantly lesser with thiazide-like diuretics, and they are the diuretics of choice. But the 2020 guidelines have said that if these are not available, it's not that we should not use these. We should not use only these diuretics. We should use available diuretics. So hydrochlorothiazide acts mainly on the distal convoluted tubule, and thiazide-like diuretics act on both the proximal segment of the distal convoluted tubule. And then we have this potassium-sparing diuretic, spironolactone, which acts in cortical collecting duct and late distal convoluted tubule. Thereby, the potassium reabsorption occurs and only the sodium exit occurs, taking all the fluid along with it. And then we have amiloride and triamterene, which act on late distal convoluted tubule and the cortical collecting duct. So the basic indications according to the type of diuretics, loop diuretics, the main or the key indications remain CKD with serum creatinine more than 1.5 or eGFR less than 30. Volume overload heart failure is a second line of treatment for volume control. Thiazide or thiazide-like diuretics. If diuretic is to be initiated or changed, prefer indapamide or chlorthalidone over the conventional hydrochlorothiazide. And the indications are first or second alternative, particularly in black patients and those aged more than 55 years. Potassium-sparing diuretics, sorry, mineralocorticoid receptor antagonist, or either in prodrug form or the natural drug form. Heart failure, resistant hypertension, and primary aldosterone remain the key indications. For amiloride, again, resistant hypertension, in addition to a thiazide or a thiazide-like diuretic, and hyperaldosteronism if spironolactone is not tolerated or gynecomastia is a significant concern. Triamterene mainly indicated for hyperaldosterone if spironolactone is not tolerated. If you see the guidelines, WHO 2003, Management of Hypertension in Blacks 2010, NICE Guidelines 2011, ESC Guidelines 2013, CHEP Guidelines 2014, JNC 8 in 2014, and the National Guidelines in 2016 have in various categories put the preferred agents. Initially started with thiazide type diuretics, then came thiazide type diuretics with calcium channel blockers, and so on. But these diuretics remain the cornerstone of our antihypertensive therapy. Thank you.
Thank you, Kamal. Is there any difference in the duration of action of thiazide diuretics and thiazide-like diuretics like chlorthalidone?
Sir, basically, all diuretics have to be given mainly as a OD dose because patient discomfort occurs significantly if we give the evening dose of a diuretic. It's only that thiazide-like diuretics are more potent as compared to hydrochlorothiazide, and the ADRs in terms of uric acid handling, and those are significantly lower with chlorthalidone.
I think we'll take more questions because time is lagging behind time.
Thank
So,
you very
Dr.
much, Dr. Kamaldeep sir, for the nice presentation.
Yeah, thank you all. Thanks.
Very nice presentation. So we'll be going for the next topic. Basically, today we are here. This is our first CME. The group is Indian Diabetes and Cardiometabolic Disease Association. So, where we'll be having today's is going on. So next topic will be Dr. Bhaskar. Can I have slides for the? So Dr. K Bhaskar, who is a MBBS Diploma Diabetology, FCPS Medicine, Mumbai, consultant physician and diabetologist, who is a co-director, consultant physician and diabetologist at Lifeline Hospital, Wagholi, Pune. There is a certification course from American Thyroid Association, then Indian Thyroid Society, 2DFO course, to Endocrine Society, Diabetes Professional Content. Has been a part of research of landmark clinical trial, which is a study in diabetes, attended national and international conferences like EDA, EASD, the member of IMA and United Diabetes Forum, invited as faculty and speaker at various conferences and workshops such as IMA workshop on diabetic food complications, Pune Physicians Group on hypertension and diabetes management. Has delivered various occupational health talks in industries and MNCs. Is instrumental in organizing the various physical and online academic events. So he'll be talking about today's topic is diabetes and hypertension. So Dr. Bhaskar, over to you.
Yeah. Thank you for introduction.
Thank you.
So thank you for introduction, Dr. Vishal. And after lectures of Dr. Kamaldeep Chawla sir and Anuradha madam, we'll come to the third lecture under our forum. And today's my topic is hypertension and diabetics. And what is the double whammy? So we'll talk about one by one. So what are the scary facts? That we all know that hypertension is very common in diabetes. Nearly 2 times it is common as compared with non-diabetic people. Hypertensives are 2.5 times at higher risk of diabetes as compared to normotensives, and it is around 35% coexisting with diabetes. So these are some figures in diabetes and hypertension, and it is quite prevalence is quite high in diabetic population, and type 2 diabetes confers an approximate twofold elevation in CVD risk. So hypertension, diabetes, they possesses CVD risk and equivalent to that of previous myocardial infarction. So what does it mean by? We all know that patient with diabetes is equal to the patient of non-diabetic who is having MI. So this is the equivalent to the patient with previous myocardial infarction. So what are the types of hypertension in diabetes patients? So as like other patients, so there are some common types of hypertension in diabetes. First one is essential hypertension, and it is mainly seen in type 2 diabetes. Hypertension may be because of diabetic nephropathy, and basically it is because of CKD-induced hypertension. See, essential hypertension is mainly seen in type 2 diabetes, and in diabetic nephropathy, this nephropathy is the cause of hypertension in mainly in type 1 diabetes. When we see the hypertension in type 1 diabetic patient, it is mainly due to the underlying diabetic nephropathy. And third entity is isolated systolic hypertension or ISH. And fourth one is nocturnal non-dippers. So I think Dr. Akash sir will take this topic under the ABPM, and this is only diagnosed with ABPM, and this ABPM is really helpful in diagnosing nocturnal non-dippers. Hypertension accelerates the onset of nephropathy in diabetic patients. In diabetic nephropathy, there is activation of RAS axis and upregulation of endothelin 1 and downregulation of vasodilating hormone nitric oxide, and which produces hypertension. I think Dr. Anuradha madam has taken this in pathophysiology. In type 1 diabetes, hypertension is often the result of underlying nephropathy, and type 2 diabetes is considered as a feature of part of metabolic syndrome. And we all know this, what are the entities under metabolic syndrome, and mainly it is the insulin resistance and compensatory hyperinsulinemia, which promotes the development of hypertension via several mechanisms. So in type 2 diabetes, mainly insulin resistance and compensatory hyperinsulinemia, which leads to different types of mechanisms, and this leads to hypertension in diabetes patients. So another new concept is that there is impaired vascular repair in type 1 and type 2 diabetic patients. And what is this? Number one is oxidative stress, which trigger the intracellular damage pathways in type 1 and type 2 diabetic patients. And because of this, there is shortage of bone marrow derived vascular regenerative cells. So in this causes there are two types of progenitor cells, like circulating progenitor cells and endothelial progenitor cells. So these cells, they are lacking in diabetic patients, and because of this there is impaired vascular repair in type 1 and type 2 diabetic patients, and this leads to many cardiovascular complications or ASCVD. So coming to the next slide, vascular processes whereby diabetes and hypertension predispose to cardiovascular disease. So already we have seen that there is genetic factors, insulin resistance, dyslipidemia, obesity. These are all common factors which leads to diabetes, hypertension. There is an interplay of these two risk factors, and which leads to atherosclerosis, endothelial dysfunction, vascular inflammation, then vascular fibrosis, arterial remodeling. This topic was already discussed in detail by previous speakers, and all these factors leads to macro and microvascular complications, which increase the cardiovascular disease. Then see, what are the different type of micro and macrovascular complications, like nephropathy, retinopathy, and cardiac complications like coronary heart disease, LVH, congestive heart failure, then PVDs and stroke. So basically, diabetes and hypertension, they have some common area, and this again promote this increase the chances of these micro and macrovascular complications. So basically, this topic was already covered, hypertension and diabetes and its pathophysiology. So basically, I would like to highlight there is increase in reactive oxygen species or ROS, and decrease in nitric oxide, increase in transforming growth factor beta, and decrease in MMPs. So this this is the basic pathophysiology in diabetic patients, and this causes vascular inflammation, endothelial dysfunction. So in diabetic patients, this is the basic pathophysiology, which increases the chances of hypertension. So coming to the next slide, tight BP control and risk of macrovascular and microvascular complications in type 2 diabetes. And we all know that UKPDS trial was the largest trial and first trial, and this was the prospective study, and it has shown that tight BP control reduces 24% reduction in events, major events. Association of systolic BP with macrovascular and microvascular complication in type 2 diabetes. So basically there are different type of trials regarding hypertension control in type 2 diabetic patients. So one of them was UKPDS trial, and it has shown that controlling hypertension is beneficial to reduce the macro and microvascular complications in diabetic patients. So twofold increase in incidence rate over the range of systolic BP from 120 to 160. So as the BP, systolic BP increases, complication increases. Then again, same is true for MI and microvascular complications. As the BP increases, chances of MI increases and chances of microvascular complication also increases. So again, coming to the next complication. So there is endpoint, any endpoint, then death related to diabetes and all-cause mortality increases as the systolic BP increases. So there is 12% decrease per 10 mm Hg reduction in systolic BP. So all we know that increase as the BP increases, complication also increases. So when we reduce the blood pressure, all these complications reduce. So it is said that even if you reduce the BP by 10 mm Hg reduction of systolic BP, there is significant increase in all the macro and microvascular complications. So to conclude remarks, in patient with type 2 diabetic patient, the risk of diabetic complication was strongly associated with raised BP blood pressure. Any reduction in BP is likely to reduce the risk of complications, with the lowest risk being in those with systolic BP less than 120 mm of Hg. So what are the effect of different BP lowering regimens on major cardiovascular events in individual with and without diabetes mellitus? So basically what will happen with patient with and without diabetes? So there were different RCTs to show that what is the difference between these two categories. And what was the outcome? Non-fatal stroke or death from cerebrovascular disease, non-fatal MI or death from coronary heart disease, including SCDs, means sudden cardiac death, heart failure causing death or requiring hospitalization, and any major events like CSD, stroke, heart failure, and total cardiovascular deaths, total mortality. So different parameters studied in detail. And what was the outcome? 36% reduction in stroke, 33% reduction in cardiovascular mortality, 27% reduction in total mortality, and 25% reduction in major cardiovascular events. So this was the outcome of benefits of BP lowering in diabetic patients. So there is always a debate, as Chawla sir has said, that there are intensive group BP reduction is helpful, but there is a data that if you go for more intensive BP reduction, mortality is also increases. There is a J type of curve in hypertension treatment. So we'll come to the what is the data and what are the trials showing the data. So there was HOT trial, hypertension optimal treatment randomized trial. So what was the inclusion criteria? So patient age was there 50 to 80 years with hypertension and diastolic BP between 100 and 115 mm of Hg. So benefits of diastolic BP lowering below 90 was studied, and another arm was 85 to below 85 and 80. So effect of intensive BP lowering on cardiovascular and renal outcome, updated systemic review and meta-analysis. So what was the outcome of this trial? Intensive BP lowering treatment achieved relative risk reduction for major cardiovascular events by 14%. And there was achieved relative risk reduction of stroke by 22%. So if you see the MI is also reduced, myocardial infarction is also reduced, and stroke is significantly reduced in intensive BP reduction group. Then not only macrovascular complications, but even microvascular complications also reduced. Means 10% reduction in albuminuria, and retinopathy was also halted by 19% of patients. Then coming to the effects of intensive BP control in type 2 diabetes mellitus. So another study was there, Accord study was there. And in Accord study also, so what was the outcome? So there was, if you see the non-fatal stroke or CVD death, there is 11% risk reduction. And secondary outcome, if you see stroke, so more benefit is for the stroke, means it is risk is reduced by 41%. So there are different guidelines also. So I will not go details into the ACC guidelines, AHA guidelines, then different ABC guidelines, ASH guidelines, because I think Dr. Chawla sir has already covered this session in detail. So recommended ASCVD risk assessment in all adults with hypertension, including adults with type 2 diabetes patients. So basically, if patient is having hypertension, you should evaluate for diabetes patients, and if patient with diabetes is there, always evaluate for hypertension and atherosclerotic cardiovascular disease, because many times they are interlinked with each other. It can be assumed that the vast majority of adults with diabetes have 10 years ASCVD risk more than 10%, placing them in the high risk category that requires initiation of antihypertensive drug therapy at BP more than 130 by 80 mm of Hg. This was also already covered by Chawla sir. Then Accord trial was a factorial study, and in Accord, secondary analysis suggested that an systolic BP less than 120 mm of Hg is superior to standard BP control in reducing LVH. So broadly, we'll go to the recommendation and class of recommendation and level of evidence, because this is very important in practice. In adults with diabetes and hypertension, antihypertensive drug treatment should be initiated. And what are these threshold levels for initiation of drugs? See, if you see, there are different type of guidelines, but there should be some consensus when we adopt in the practice. So we cannot go by different guidelines every time. So we have to follow the consensus guidelines. So BP of 130, 80 mm of Hg or higher with a treatment goal of less than 130, 80 mm of Hg, and class of recommendation is 1. So level of evidence is B, and for diastolic it is C. So basically, initiate treatment if the BP is more than 130/80, and goal is to reduce the BP below 130/80. So it is a class 1 recommendation. And in adults with diabetes, hypertension, all first line classes of antihypertensive agents like diuretics, ACE inhibitors, ARBs, CCBs are useful and effective. And we have to see for the any contraindications for each and every molecule. In adults with diabetes and hypertension, AC inhibitors or ARBs may be considered in the presence of albuminuria. Means if there is a albuminuria, always consider AC inhibitors or ARBs from the armamentarium of different type of antihypertensives. So what 2018 ESC guidelines says in the management of hypertension. So they also suggested that antihypertensive drug treatment is recommended for people with diabetes when BP is more than 140/90. This is a class 1 evidence. And class 1A is systolic BP more than 130 should be treated, and it should be reduced below 130/80 if tolerated, and if it is not below 120. So if you reduce below 120, patient will become symptomatic for hypertension. There may be rise in creatinine, patient may get giddiness. In older people with having age of more than 65 years age, to target a systolic BP of 130 to 139. See, in elderly people, we have to give, we should not reduce the BP too much, especially systolic BP. And what should be the target diastolic BP? Less than 80 mmHg, but not below 70 mmHg. So these guidelines are very helpful and useful in practice. It is recommended to initiate treatment with a combination of RAS blocker with a CCB or TZD-like diuretics, and simultaneous administration of 2 RAS blockers like AC inhibitors and ARBs is not indicated. And we all know that this previously we were using AC inhibitors and ARBs in combination, and later on data came that we should not use in combination. And there are different Indian guidelines also, and this was also covered by sir. So in practice, we should always think what are the thresholds for treatment and targets for BP reduction. But if you see there are guidelines for different risk categories and different age groups. But if you see for the diabetes, so threshold to start treatment is 140/80. And what is our target range is 130 to 140, and diastolic BP 70 to 80. So this is very simple and simple to follow. So guidelines for selecting most appropriate first line antihypertensive drugs. So if you see the in diabetic patient, we can use diuretics also, we can use CCBs also, AC inhibitors also, and ARBs also. But for diabetic patients, we should use AC inhibitors and ARBs if there is albuminuria. So thank you for giving time. So if you have any questions, we'll address these questions also.
Thank you, Dr. Bhaskar. Particularly well explained topic. Participants?
So should I stop the slide sharing?
So today we have discussed 3 topics already in this particular forum, which is newly formed, which is Indian Diabetes and Cardiometabolic Disease Association. So we'll be discussing the topics like this further also. So today's last topic will be presented by Dr. Akash Kumar Singh, who is a MD Internal Medicine, MSc Diabetes, Cardiac University, UK, Senior Consultant Physician, Cardiologist and Diabetologist, who is a Director in Spandan Multispeciality Hospital, Majalpur Hospital Private Limited, member of COVID-19 Management Committee, Vadodara, PDCC Diabetes, John Hopkins University, USA, Diploma in Diabetes Management, Middlesex University, UK, PG Diploma in Diabetes, MSc in Diabetes, Cardiff University, UK. Multiple orations in diabetes state level conferences. Vice President Association of Physicians of Vadodara. Executive member of Association of Physicians of Gujarat. Member ACP, ASC and Endocrine Society, ADA, ERS, ESC, EASD, RSSDI, API, and so many. International associate accordingly. Today's topic he'll be covering ambulatory blood pressure monitoring. So Dr. Akash sir, over to you.
Thank you, Vishal. So we are a little late, running late by at least 10 minutes. So I'll be fast on my topic. So my talk today is on the role and importance of ambulatory BP monitoring. Blood pressure is the lateral pressure exerted by the flowing blood on the walls of arteries. Hypertension is greater than normal blood pressure. It is one of the most important contributors to morbidity and mortality in general. BP depends on number of factors, so it may be both intrinsic or extrinsic, and a single value may not be true representation of the actual BP. Now, the benefits of BP control already innovated by Dr. Bhaskar. 10 millimeter of systolic blood pressure reduction can lead to reduction of 50 to 60% of the stroke death, 40 to 50% of the CAD death, 50% lower risk of heart failure. And these benefits are greater in old ages and at higher initial BP readings. Now, if you do the BP accurately, then you are doing great service to society. But if you do not place importance to BP or take it inaccurately, then you are doing more harm than good to your patients. Now, traditional method of BP measurement, the office-based BP measurement is enormous, has enormous value, and is the only practical approach in population level. Inherent variability of blood pressure is there, which is unfortunately missed by office BP. Patterns of hypertension is not picked up in casual office BP measurement. Now, casual blood pressure is a measurement where the patient comes in and you take it with immediately. That is a casual BP measurement. The resting blood pressure is that patient is seated, he is there for 5 to 10 minutes, and he is at rest, and then you take. And standing blood pressure we take to rule out orthostatic hypertension, which you have seen is seen with so many conditions. Now, these are the prerequisites of taking this thing. If you do not follow these prerequisites, then you will end up with the elevations of BP, which are shown on the right side. So the first thing is that the blood pressure should be, patient should be at rest for more than 5 minutes. If it is not in rest, you take it immediately. You may record BP higher by 12 to 6 millimeters systolic and diastolic. If he is seated without a proper back support, then his BP may rise by 6 to 8 millimeters mercury. If cuff is not at mid-sternal level, then there may be reduction because the BP estimate is lower than your cuff level. Correct cuff size. If the cuff size is not correct, if it is not covering a 80 to 100% of the arm circumference, blood pressure will be erroneous. Bladder center over artery, if it is not centered over the artery, then again erroneous BP. If you deflate very fast, then you will end up recording systolic blood pressure on the higher side and diastolic on the lower side. If initial BP is more than goal BP, then you should take 3 readings and you should discard the first reading and then average the last 2 readings, because first reading will be on the higher side. Now, to get over all these limitations of office-based blood pressure, ABPM was initially developed. Actually, the history of ABPM is that it was developed basically for research purposes, and the first device was developed in 1960. You can see the first device. Now, ambulatory BP monitoring involves measuring blood pressure at regular intervals, that is every 20 to 30 minutes over 24-hour period, while patients undergo a normal daily activity, including sleep. The portable monitor is worn on a belt connected to a standard cuff on the upper arm. When complete, the device is connected to a computer, and we can download the data on the computer, and we get everything on the computer. The entire printout comes out with all the interpretations needed. So basically, the technique is automated oscillatory BP apparatus performed on a single working day. Cuff applied in non-dominant arm. Cuff should be covering 80 to 100% of the arm circumference. Patient is should be told to follow the usual activities, but to remain still during measurements with the arm relaxed at heart level. We have to place a monitor at the bed or beneath the pillow at night when they sleep. should not take shower or bath, should preferably avoid driving. Oral and written instructions and a diary card to be recorded. They should record the time of medicines they are taking, time of getting up, time of going to bed, and any symptoms they note during the day. 24-hour minimum, 70% of the expected reading should be okay, and at least 20% valid readings during the day, and at least 7 valid readings during the night. Because a lot of these readings will also get invalidated if the patient is moving and if his proper BP is not measured. Now, there is something called as BP variability. Now, there are physiological variations BP. Systolic and diastolic blood pressure gradually rise with age after the age of 30 years. Systolic blood pressure may be more there may be more rise in the systolic blood pressure compared to diastolic blood pressure with the aging, basically. Sex, the rise in BP is with age is greater in males. There is circadian rhythm because there is a BP down drops to 10 to 20% after sleep and rises during the morning when you wake up. That is the morning surge and the night dipping. Increase transiently during physical stress, mental stress, emotional excitement. And if your BP instrument is not at the level of your arm, there may be, because of gravity, some difference in the BP. Now, there are several terms which you use basically without much knowledge of the implications of these terms. One is BP variability. BP normally fluctuates from day to day. Pronounced fluctuations, BP can occur over short or long-term periods. Episodic hypertension is also known, especially in TIA patients. BP variability is difficult to measure in routine clinical practice. There is no clearly defined or widely adopted diagnostic definitions or treatment goals. Now, there is something called a BP detector. Here, the BP shoots up in response to something like a patient exposed to cold, a patient getting into a certain situation, like a patient coming to, you can say that white coat hypertension, patient coming to clinic has a BP. So there are a lot of factors which cause blood pressure to go up, basically. It is suspected to be predictive of future development of hypertension and CV risk. There is something called as what we call labile risk. This is a term created by us. What happens is that the same person, the BP basically is normal. Sometimes it goes up. So there are various terms to define fluctuations of BP recording the same person. All of these terms can be used. Nobody knows their proper interpretation. So basically, why this BP variability occurs, there's several mechanisms why this BP variability occurs. One is the increased sympathetic drive driven by certain drug or certain situation, arterial or cardiopulmonary reflux activity or sleep. Like in OSA, basically, once the oxygen levels drop during the sleep, the BP will tendency to go up. There is a decreased arterial compliance, inappropriate dosing or titration of antihypertensive agents, or decreased adherence to antihypertensive agents, basically. So if you can see, if this person has autonomic dysfunction, like you see in patient of advanced Parkinsonism, the BP will fluctuate markedly. It will fluctuate by 40 milligrams, 50 milligrams, and these pronounced fluctuations in BP can lead to a sudden LVF or a sudden MI. So it can drive complications, basically. So pronounced fluctuations in BP can occur over short-term and long-term observation periods. So these are the things: BP variability. It may be reading to beat-to-beat variability. It may be a day-to-day variability, or it may be weekly variability or visit-to-visit variability. Instability, maximum BP, office, home, ambulatory monitoring, morning BP surge, ambulatory monitoring. So all these will sort of let you know whether the BP is unstable. And reactivity, you can do the practical test like isometric or isotonic exercise testing, cold pressure test, etc., etc. Now, they may carry different clinical implications, but these are still not properly understood. Now, you can see this patient, he has some amount of fluctuation, but this patient has marked fluctuation. So this patient has higher BP variability, which will translate into higher risk of cardiovascular disease, morbidity, and mortality. Now, the factors associated with BP variation as average BP levels, heart rate, temperature, diabetes, smoking, increasing age, presence of vascular stiffness, poor compliance with antihypertensives, and they will lead to subclinical cerebral ischemia, increasing arterial stiffness, and impaired baroreceptor response. Now, the setting will affect whether the patient has office BP, is at work, is ambulatory BP, or home BP. Time, as I told you, there is diurnal variation. So time at which you record the BP will also affect the measurement of BP. Observer, if a doctor observes the patient is more frightful, BP will be more. If a nurse, then the BP will settle down a bit. Technician, and if he takes a home BP, then his BP will be at the lowest, at the baseline basically. So if fearful physician of meeting a doctor or nurse basically will cause some elevation of BP. The device also, there are various types of devices available, and now we have LED and a lot of other devices. So that will also affect posture, whether the patient is lying or is seated or standing or exercising. Then readings also will affect it. Generally, we have seen that first reading is on the higher side, but you have to take the subsequent readings if the first reading comes on the higher side, so that you get the actual readings basically. Calculation, how you calculate the BP basically, whether you take mean, mode, median, all those things will affect the BP. Now, what is surrogate BP and what is true BP? Now, whenever a patient comes to you for treatment and you take the BP, and that BP may not be a true BP basically, the patient may have got frightened and BP will come on the higher side. So that is called as surrogate BP. What we intend to treat and what we intend to know is the true BP of the patient. Now, evaluation of ambulatory blood pressure monitoring data, you have to have a definition of the daytime and nighttime. Generally, time between 9 a.m. to 9 p.m. is taken as the daytime, and time between 1 a.m. to 6 in the morning is taken as nighttime. Editing is not necessary for calculating 24-hour blood pressure, daytime and nighttime values. Everything is done by the machine. If you download the data on the computer, everything comes in. As we see that at least we should have 20 valid observations between 9 a.m. to 9 p.m. and 7 valid BP observations between 1 a.m. and 6 p.m. 6 a.m. Blood pressure measurement should be done at 30 minutes interval. For research purposes, at least 2 valid daytime and 1 valid nighttime measurement per hour should be done, which should be corroborated with the BP. Now, the definition for hypertension, the ABPM is if the average 24-hour BP is more than 130/80, awake BP, daytime BP is more than 135/85, and if the nighttime average BP is more than 120/70. So these are the definition of hypertension as far as the ambulatory BP monitoring is concerned. Now, if you compare the office-based BP measurement with the home-based BP measurement with the ABPM, cost is definitely higher with the ABPM. Medical requirements definitely higher with the ABPM. Need for training definitely higher with the ABPM. Duration of procedure long, that is 24 hours with ABPM. Validated accuracy. The best validation, best accuracy is with ABPM device, because if you use this device, you have to calibrate it once a year or so. So basically, you cannot use it, go on using it in uncalibrated state. So ABPM gives a very accurate reading basically as the blood pressure is concerned. If you see the systolic blood pressure, then already we have seen the values. The common BP definition say that systolic blood pressure is more than 139 and diastolic more than 90. Isolated systolic is systolic more than 140 and diastolic less than 90. That is best assessed by ABPM, and in ABPM we use systolic more than 130 and diastolic less than 80 on an average. So the definitions of BP will change as far as the office-based BP instrument is concerned. This is ABPM. ABPM will have lesser values compared to the office-based BP measurement, because ABPM the values are less as the patient is relaxed and patient is not having a white coat effect. ABPM patterns cannot be diagnosed, variations of the BP cannot be diagnosed with office-based instruments. They have to be, they are evident only in ABPM. Now, if you see the target organ damage, cardiovascular morbidity, mortality, it is best predicted by ABPM basically, rather than the office-based BP measurements. And provision of indices is only possible with ABPM. So ABPM is definitely a lot superior to the office-based measurements and much superior to home-based measurements. But it has higher cost and it is a cumbersome procedure, so it cannot be done on routine basis, but should be considered in wherever the situation demands. The home-based BP instruments measurement is also good, but there are a lot of substandard instruments available in the market, and I've seen a lot of patients getting into BP mania, the use of these instruments. So ambulatory blood pressure monitoring detects the true or mean blood pressure, diurnal blood pressure rhythm, dipping status, morning surge, blood pressure variability, and duration of drug effects, which cannot be detected by majority of the other modes like the office and the home-based BP measurements. So the advantage of ABPM over clearing BP is that it gives a larger number of readings than office-based measurements, provides a profile of blood pressure behavior in the patient's usual daily environment, allows identification of white cures or mass hypertension phenomena, demonstrates nocturnal hypertension, assesses blood pressure variability over the 24-hour period, assesses the 24-hour efficacy of anti-hypertensive medication, is a strong predictor of cardiovascular morbidity and mortality than office-based measurements. The diurnal variations, which already we have seen, basically we will not go into detail, but this is the graph. You can see that this is the time that is the midnight and the BP falls, and here patient gets up at 6 a.m. and there is a morning surge of blood pressure. So this morning surge of blood pressure is very important because majority of the CBD mortality, that is the stroke, the MI, the LVS, will occur with this morning surge, and this morning surge has to be effectively controlled. So dipping is basically the blood pressure will fall to the tune of 10 to 20% during the night time is called dipping. Reduced dipping is the fall is less than 10% of the baseline blood pressure, that is non-dipping. Reduced dipping, if there is non-dipping or rising blood pressure, that is the blood pressure is more after sleep than before sleep, that is a non-dipper rising status, that is a very, very bad prognostic indicator because there is excessive risk of morbidity and mortality. Extreme dipping is if the blood pressure falls more than 20% of the daytime value. It is called extreme BP. You have to evaluate this patient, especially the pharmacotherapy that you are giving to this patient, and you have to sort of take care of that. Nocturnal hypertension is blood pressure which rises during the night, as you see commonly in conditions like obstructive sleep apnea. Morning surge, we have already seen that there is a rise in the blood pressure in the morning, but that if the rise is excessive, then you are in trouble. So the clinical indications of APM is white coat hypertension, false resistant hypertension, treated patients, mass hypertension, daytime hypertension, nocturnal hypertension, assessment of treatment, assessing hypertension in children and adolescents, assessing hypertension in pregnancy, elderly, ambulatory hypotension, endocrine hypertension. In the elderly, you want to know about the isolated systolic hypertension and nocturnal hypertension. Isolated diastolic hypertension in younger individuals is a common entity, best predictors of cardiovascular risk from nocturnal blood pressure. BP variability you want to know, ambulatory hypertension you want to know, and Parkinson's disease I told you is having a lot of cardiac or autonomic dysautonomia leading to a wide fluctuation of blood pressure. Pheochromocytoma, Addison's disease, hyperthyroidism, all these will lead to variations in the blood pressure, which should be measured with ABPM. Atrial fibrillation, the diastolic blood pressure measured by ABPM will be higher. It is also used in clinical trials for anti-hypertensive drug effects. So this is the algorithm. Any patient who is there more than 140/90 and who is a low risk, basically, you can ask him to self-monitor blood pressure. But if the patient is having BP of 140/90, that is by borderline BP, or a BP of 130/80 plus, with multiple target organ involvement, then you like to subject this patient to ambulatory BP monitoring and decide about the level of blood pressure. Why, I will tell you in the coming slides. Now, the limitations of APM, it is limited availability, discomfort at night, reluctance to use repeatedly by the patient, cost, and function is imperfect reproducibility, intermittent measurement in sedentary and ambulatory versus ambulatory condition, inaccurate reading during activity. Now, these are the different guidelines which all recommend doing ABPM in majority of the conditions like white coat hypertension, labile hypertension, persistent hypertension, hypotensive episodes, and postural hypertension. Now, the patterns of blood pressure that you see is white coat effect, white coat hypertension, mass hypertension, and nocturnal hypertension. So, what is white coat hypertension? The patient has normal BP at home, but when he comes to the doctor, then the BP is recorded on the higher side. Generally, these patients do not have much excess cardiovascular morbidity and mortality. White coat effect is the patient already hypertensive, but in the chamber, the BP comes even up. At home, he may be controlled with the antihypertensive agents, but in the clinic, his blood pressure comes up basically, and that is white coat effect. And generally, prognosis here is good. if there is no target or organ damage. Masked hypertension is if patient BP is controlled at clinic, but outside clinic the blood pressure, it is reverse of white coat hypertension. The masked uncontrolled hypertension is that patient is already on treatment of blood pressure. His BP recordings are normal in the clinic and elevated at home. Now we see the reduction of white coat effect in clinical practice. This is once the patient comes to physician, the same patient with the research technician, the same patient with BP2, that is home-based measurement, and the same patient with ambulatory BP monitoring. So you can see that patient who is having BP of 152 systolic basically is actually having BP of 132, 134 with the use of ambulatory monitoring. So this is the white coat effect, and it can be minimized with by taking the blood pressure at home or with the help of ABPM. Now, this was a study of 390 patients referred for diagnosis and management of hypertension, and they concluded that the white coat response was associated with office-based BP measurements can virtually be limited by recording BP with automated BP2 device with patients resting alone in a quiet, relaxing examining room. So that home-based BP instrument is the thing basically to have a proper assessment of blood pressure control basically. And you know that the sprint trial basically which led to alteration of the guidelines, AHA, ACC guidelines basically, did use home-based BP instrument, which is generally 5 to 10 millimeters mercury lower than the office-based BP instrument, and that is the reason why the patients who had BP on the lower side did well, because their BP of 130 may reflect BP of 140 done with the earlier trials, because all the earlier trials have used the office-based BP instrument for BP control. Now we'll see this patient, gentleman, this lady has basically white coat hypertension, BP up in the clinic and normal with ABPM. Now, prognosis of white coat hypertension and white coat effect. The data regarding cardiovascular risk of white coat hypertension are conflicting, probably related to differences in anti-hypertensive treatment status in different studies. Untreated white coat hypertension seems to be associated with higher risk of adverse cardiovascular outcomes compared with normal tension, although this risk may be lower in magnitude than the risk of masked or sustained hypertension. By contrast, white coat effect is not associated with elevated cardiovascular risk compared with sustained normal tension, although one study reported in association of white coat effect with the development of end-stage kidney disease. Now, this is a case of masked hypertension. You can see that office-based BP instrument is okay, but home-based BP instrument is on the higher side. So this is a reverse phenomena. Masked and masked uncontrolled hypertension are consistently associated with the increased risk of major adverse cardiovascular events and all-cause mortality similar to that of sustained hypertension. So compared to white coat hypertension and white coat effect, the masked hypertension, masked uncontrolled hypertension are having a worse prognosis. Who to evaluate for masked or masked uncontrolled hypertension? Now the guidelines say that if a patient is having a BP almost near normal range, you are happy that patient is having a BP near, but he has multiple risk factors or target organ damage already in place. Such patients should be subjected to ABPM, and if their BP is controlled at home, well and good. If their BP is not well controlled at home, then you should reevaluate your therapy and you should try to control the blood pressure even further, basically, so that future risk of these acceleration of these organ damage is sort of ameliorated, and the patients do well over the long term. So they have very, very clear-cut guidelines that a near normal, like a patient who has diabetes, CKD, whose BP is coming 138 by say 80 at your clinic, then you subject this patient to ABPM, and you see the blood pressure remains the same at home. If the blood pressure is recorded higher at home, then you further reduce the blood pressure in this patient to decrease the progression of CVD risk factors and CKD risk factors. Now, if you see various studies of ambulatory BP monitoring versus office BP monitoring, and you can see that ABP will have a better predictor of outcomes compared to the office-based monitoring figures, basically. So it is very clear that ABPM gives better prediction of long-term morbidity and mortality on the CVD front, basically, compared to the office-based BP instrument. Now, what is the prognostic value of ambulatory BP recording patients with treated hypertension? And you can see that less than 140, better prognosis. This is the 24-hour ambulatory BP monitoring is showing systolic less than 135, prognosis better. If it's showing more than 135, prognosis worse, basically. So for all categories of blood pressure, if the ambulatory BP monitoring is showing a higher levels, even on ambulatory BP monitorings, then the prognosis would be bad, basically, for these patients. Now, this is what you see. This is the clinic BP. The BP here recorded here is around 140. A home BP, it is little less. On the ABPM, the systolic BP may be recorded even less, basically. So the average BP may be less than what you record in your clinic, basically. This is the nocturnal dip. This is the early morning surge. Now, if you see the nocturnal hypertension, this is the time between, you can say, around 11 p.m. to 6 a.m. You can see the BP going up here, and this is the nocturnal surge, which has a bad prognosis. So this is the standard report card of a ABPM, basically. You can see that this is the overall summary. This is the wake period. This is the number of wake period readings. This is the sleep period. This is the number of sleep readings. And you see the average readings here. The average systolic is this, 119. Average diastolic is 68. With the daytime, this is 125/73. This is the daytime reading. This is the average 24-hour reading. And the average nighttime reading is 104/58. Number of readings you can say during the night is 18, during the day 66. So practically a validated report, which should be considered valid, and the patient is normotensive. He does not have accelerated hypertension. So if you see the patterns of hypertension, white coat effect, your clinic pressure will record it up, and a mass hypertension, your pressure, ambulatory pressure will be less than what is there seen in your clinic, basically. Now, the prevalence of white coat hypertension, mass hypertension is very, very good, basically, because you can see that a lot of patients are having white coat effect and a lot of patients have mass hypertension. This is not an uncommon entity. We should look for it, and it will basically tell us the story, basically, and how to manage the patient. Now, if you see the target organ damage with a normal BP, less damage, left ventricular mass index, white coat hypertension, again, not much of a difference, but sustained hypertension, there is a LV myocardial infarction increases, LV mass increases. The E to A ratio, normal E to A ratio is 1.24, little less in white coat hypertension and definitely less in systolic hypertension. E to the A ratio denotes the diastolic stiffness. So all the cardiac parameters are basically worse for sustained hypertension, little worse for white coat hypertension compared to normal blood pressure individuals without BP, much of BP variability. So the same is seen with mass hypertension, but in mass hypertension, you can see that there is a good rise in the risk. LV mass index is much higher than normal blood pressure. The CV event, the hazard ratio is much more. So mass hypertension is a much more bad entity than white hypertension. That is why the AHA ACC guidelines have said that patients coming to with near normal blood pressure, if they have multiple target organ damage, then you have to subject them to ABPM and see if the blood pressure remains normal even at home. If the blood pressure is recorded on a higher side at home, then you have to aggressively treat these patients. So blood pressure dipping status, normal pattern is 10 to 20% dipping, coincides with hours of sleep. Non-dipping pattern, basically absence of normal nocturnal fall in blood pressure. 25% of hypertensive have this pattern, especially the African Americans, the diabetics, and the CKD population. The diurnal pattern, circadian rhythm abnormalities pattern are associated with increased CV events. Dipping is good. The non-dipping pattern is associated with increased risk of MI, stroke, dementia, as blood pressure remains elevated during sleep. Dipping patterns and declining GFR, you can see that patients who basically are having good dipping are having less incidence of kidney injury, but those who are non-dippers or any elevated blood pressure have more evidence of kidney injury. Now, the role of ABPM in resistant hypertension, Spanish ambulatory blood pressure registry, 8,295 patients. After 24-hour ABPM, 62.5% only had true resistant hypertension. 37.5% had white coat hypertension. So, all those patients which you are having who are having a persistently elevated blood pressure at your clinic should subject to ABPM, and 1/3 of them would turn out to be normal. So these are the normal readings for blood pressure. This is the home-based pressure, 135/85 is normal. For daytime average ambulatory BP 135/85 is normal, and 24-hour average ambulatory BP 130/80 is normal. This coincides with office-based BP instrument BP reading of 140/90. So important role of home blood pressure measurement. Measuring blood pressure at home has a stronger association with CVD prognosis than office-based readings. Home measurements can help to confirm the diagnosis of hypertension, improve blood pressure control, reduce the need for medications, improve medication adherence in non-resident patients, help to identify white coat and masked hypertension. So the conclusion is the ABPM helps define those with sustained hypertension, estimates target organ damage and cardiovascular events more accurately, defines those that need more aggressive office-based blood pressure control, identifies those with true resistant hypertension. So with this, I will end my lecture. I thank you very much for your attention, and we'll be happy to take questions if any. We are pretty late on time, but
thank you, Akash sir. Thank you very much for this detailed lecture, and thank you very much for this detailed information given for ABPM. There are a lot of questions which are going on.
right. So, please.
Most of the things you have already discussed actually regarding these questions, but still there are like some questions like Dr. Gupta has asked white collar hypertension and treatment for resistant hypertension is already discussed. From Manju, Dr. Manju from Nagpur has asked which are the best molecule to control systolic hypertension, how to control hypertensive heart failure and encephalopathy.
So I think we'll discuss the questions even if they are discussed in brief again. So what is the treatment for masked hypertension? So basically, I already alluded to that basically because masked hypertension is something to be treated. The ACC and AHA guidelines for masked hypertension say that you have, because masked hypertension can only be treated by home-based blood pressure measurement or by ABPM, and ABPM is a superior instrument to detect masked hypertension. And as we have already seen that masked hypertension has worse prognosis as far as the cardiovascular risk is concerned, future cardiovascular risk is concerned. So you have to basically titrate your therapy, rather up titrate your therapy basically, and control the blood pressure even at home. And you should see the BP control again with a repeat ABPM basically, so that you are sure that patient's blood pressure even at home is controlled. So masked hypertension is to be definitely treated, and the implications of not treating masked hypertension are bad because patient will have excess cardiovascular morbidity and mortality. So that is regarding the masked hypertension. Dr. Vishal from
Which are the best molecule to control systolic hypertension? How to control hypertensive heart failure and encephalopathy? This is a question by Dr. Manju, Nagpur.
Achha. Right, just a minute. What is the question? Is the question?
Which are the best molecule to control systolic hypertension? How to control hypertensive heart failure and encephalopathy?
Now, the best molecule for control of systolic hypertension, there is no such molecule. You have to individualize your treatment as per your patient who is there. Like a patient who is a African patient, the best agent will be obviously calcium channel blocker. If a patient has a systolic elevation of systolic blood pressure, you have to go to the basic pathophysiology of the disease basically. If you want to treat, if you suppose a young patient who is a sympathetic overdrive, then the best.
Categorize the patient basically.
You have to categorize. You have to give the beta blockers basically. So basically, you have to go to the pathophysiology and individualize the patient, and then treat. If patient has a heart failure, obviously ACE inhibitors or ARBs or RV is the best combination. So calcium channel blockers always come in handy as a second agent basically once these first agents have failed, or they may use as a first agent in, as I told, African Americans. So you have to individualize the patient and accordingly. Regarding the hypertensive heart failure, we have to basically bring down the heart and bring down the blood pressure effectively with the use of ACE inhibitors, ARBs, and you have to use here beta blockers too, diuretics too. So all these are to be used. So you have to, and regarding the encephalopathy, there is no drug specifically to be used in encephalopathy. Antihypertensive drug. You will come out of hypertension.
Or control hypertension basically.
Once you control the hypertension. Now
So
regarding
Dr. Ajay has asked one more question: use of chlorothalidone and why it is better than hydrochlorothiazide.
Should I answer or would anybody else answer?
Dr. Chawla is there.
Dr. Chawla has just gone basically.
I just left.
Basically, see, hydrochlorothiazide and chlorothalidone, if you compare. So chlorothalidone has longer duration of action and it has got lesser electrolyte imbalance, and it gives smoother BP control reduction. So that's why it is better than hydrochlorothiazide.
Even fluctuations are less commonly seen with chlorothalidone.
Yes. So these are the three reasons.
Right. So as Dr. Bhaskar said, this is a more potent molecule which is a longer duration of action. A proper OD
dose properly can be maintained.
And actually if you see all the guidelines, hydrochlorothiazide is gradually fading out because of the obvious advantages of chlorothalidone, and the only molecule that can match up to chlorothalidone is indapamide, which is very, very costly.
Right.
Yes.
So now there is another question from Dr. Amit Baroda. Heart failure with bradycardia. Can we use beta blocker?
Heart failure, bradycardia, we should not use beta blocker because in heart failure, our target heart rate is around 60. So we cannot accept a patient whose heart rate may drop to
there is a high
days.
chance of failure to get
the basic purpose of using beta blockers is to bring down the heart rate. If the heart rate is already down,
bradycardia, there is
we cannot use.
Okay, Dr. Avinash from Agra has asked one more question. New normal therapeutic target for hypertension management in COVID perspectives.
In COVID perspective, basically we don't have any variation from the normal guidelines. In the COVID, the guidelines definitely would remain the same as the normal guidelines are basically. And if the patient is critical, then it is wise not to bring down the BP too much, because a lot of these patients will end up with cytokine storm or with sepsis, where their BP may suddenly drop and will end up with injury. So basically, the BP targets are the same as in non-COVID patients. There are no variation from BP targets.
No difference as such. Only thing that there is a tight control which is advised, I think so, no, in the COVID perspective, or what they are saying. Just to avoid the complications of COVID.
But the target should be the same basically. We will not go for any different target.
So Dr. Suraj from Ahmedabad, one more question. What is the ideal target BP during pregnancy?
The ideal target BP during pregnancy is again the same as the normal target basically. And
Dr. Bhaskar has already answered this question, I think so, in chat box.
Yes. Ideal target is
blood pressure is around 120 to 129, and diastolic blood pressure is around 65 to 79 millimeters of mercury.
Yes. So basically, we should go for tighter BP control in pregnancy.
In pregnancy. Okay, Dr. Neeraj from Surat is one more question. What is the treatment for masked hypertension?
So that was already discussed. That
Already
was the
explained.
first thing we discussed.
Yes. And
Now,
another thing is Dr. Vishal from Baroda has asked, in temperate, hot, humid environment, quite often I have seen that hypertensive patients who are on AC inhibitor or on ARB suddenly develop hypotension and hyponatremia. What is your experience?
no, that is particularly very true because what happens is that in the hot, humid temperatures, because of the excess perspiration, there may be some element of dehydration, and any element of dehydration, it may be because of excessive perspiration or a illness or a poor oral intake, will lead to sudden drop of the blood pressure and acute kidney injury in these patients. So all the patients of ACE inhibitors, ARBs, have to be adequately hydrated. Basically, if the hydration is not taken care of, then definitely a very relevant point from Dr. Neeraj that patients will get into some complications basically. So that patient education here is quite important on that front.
So to be hydrated, stay hydrated in that particular conditions.
Right.
Okay, so these are the questions actually. Now
there is one more question which says the risk of hydrochlorothiazide with malignancy. So there is suggestion of increased risk of squamous cell carcinoma, especially of the lip, with use of hydrochlorothiazide. But fortunately, we have not seen much of these cases in our day-to-day practice. So this seems to be more of a very
theoretical right now.
Theoretical or very less risk, because I don't think any of us, despite using so much of hydrochlorothiazide, have seen much of.
We have never seen. Okay.
So I think we have taken all the questions.
Yes.
So
this last session is also over. So I think so. This particular association will go on further, and there are some further CMAs also will conduct.
So we will be basically now involving more and more of our physician colleagues and diabetology colleagues and endocrinology colleagues for arranging larger sessions, and we will also be in future planning to launch a textbook of diabetes. Also, our plans are to start PDCC in diabetes and diabetocardiology and diploma in diabetes and diabetocardiology. All the material and infrastructure of that is ready. So we are basically planning to expand gradually into and foray into further fields as far as the academics is concerned. And we will like to have cooperation of you all. Basically, I thank all the my colleagues who have joined this program basically and have been with us, and I'm especially thankful to those who have especially asked the questions in this program. I also am very much thankful to the IPCA company basically for arranging this digital webinar for us. And as I heard from them, the presence is approaching almost 1,000. And we are very sure that a lot of patients, a lot of our colleagues are attending, looking at the flow of questions, which have been almost 10 plus. So again, I thank the IPCA people for arranging this digital webinar. I hand over the session to Mr. Mohan to close the meeting basically.
Yes, sir. So thank you, sir. This was an academic initiative from IPCA Laboratories Limited in collaboration with Indian Diabetes and Cardiometabolic Diseases Association. So I, on behalf of IPCA Laboratories Limited, would like to take this opportunity to thank all the eminent panelists and moderator of today's webinar. At the same time, I also must take this opportunity to thank my sincere thanks to all the viewers. My special thank goes to Dr. Akash Kumar Singh from Baroda, Dr. Kamaldeep Chawla from Baroda, Dr. Anuradha Kapoor from Mumbai, Dr. K Bhaskar from Pune, and Dr. Vishal Chawdhari, who was the moderator of today's program from Mumbai. So once again, my sincere thanks to all of you. And last but not the least, I wish you all a very, very happy and prosperous Navratri Puja. Thank you. Thanks to all of you.
Thank you very much. Thank you.
Thank you very much. Yeah.
Yeah.